Good morning, one and all. We are about to begin our instruction course on mistakes to avoid in glaucoma management. Glaucoma is a leading cause of irreversible blindness, which can be prevented if detected and managed early. Glaucoma management comes in the domain of comprehensive ophthalmologist as well as a specialist. Hence, every attempt should be made to promote the right practice pattern and improve the standard of glaucoma care among the budding ophthalmologists and general ophthalmic surgeons. That includes right clinical examination techniques, OCT interpretations, field analysis, and the medical and surgical management. The purpose of this instruction course is to discuss the commonly occurring mistakes while managing glaucoma patients and the knowledge of which can improve the patient care with a better outcome. So we are starting with the topic Top Mistakes in IOP Management by Dr. Ashwati. She is the assistant professor in Government Medical College, Thrissur. Over to you, Ashwati.
Good morning, all. To diagnose glaucoma, we need all of this. But the most important, I would say, is the intraocular pressure because that is the one parameter we can modify and manipulate. Therein lies the importance of tonometry. Are we doing it in the right way? And what are the common mistakes that we make while measuring IOP? Over time, we have had a lot of instruments to measure IOP, but one thing that has emerged as a favorite is the Goldman applanation tonometer. Even that is marked by a lot of variability in the biomechanics, corneal biomechanics, and a few newer ones like the dynamic contour tonometer and the ocular response analyzer has come up, but it's not much use because it's more expensive and a lot time consuming. So still our favorite is the Goldman applanation tonometer. As we know, the Goldman applanation tonometer is based on the Imbert fixed law, that is force applied externally is equal to pressure within the sphere multiplied by the area of applanation. But the validity of the law requires that the sphere be perfectly spherical, dry, perfectly flexible, and infinitely thin. None of this criteria is met by the globe. So, what are the more common? That itself is a cause of error, and the most common error of this comes from corneal thickness. Because the mathematical calculation for GAT is based on the presumed average corneal thickness of 520 microns. And from various studies, we have come to know that in the population, the CCT can vary widely from 500 to 600 microns. So for every 0.7, for every 10 micron deviation from the average, we'll have an average error of 0.7 millimeters of mercury. Thicker the cornea, the higher the IOP measured, and thinner the cornea, the lower the IOP will be measured. This has applications in corneal refractive procedures. So, if the patient has undergone procedures like LASIK and PRK, that would cause a thinning of cornea leading to an underestimation of IOP, which can persist up to 1 year. Therefore, tonopen or ocular response analyzer may be more reliable in patients who have had corneal surgery. Another one is a corneal curvature. An increase of approximately 1 millimeter mercury will be there for every 3 diopters of increase in corneal power. And similarly, for corneal astigmatism, IOP is underestimated for with the rule astigmatism and overestimated for against the rule astigmatism, approximately 1 millimeter for every 3 diopters of astigmatism. How can we circumvent this problem? You can either rotate the biprism until the dividing line between the prism is at 45 degrees to the major axis of the ellipse, or you can take both a horizontal and vertical reading and get an average of the two. Now, if the patient has more than 3 diopters of astigmatism, it is better to align the axis of the minus cylinder with the red mark on the tonometer head, which would give a more accurate value. A scarred or irregular cornea distorts the fluorescein rings and make it difficult to estimate the IOP. So, if the cornea is thick because of additional tissue, IOP is overestimated. This similar is the case in case of band keratomyopathy, where the calcium present within the cornea makes it more rigid, and hence IOP will be overestimated. And in keratoconus and other ectatic conditions, which would cause thinning of the cornea, the IOP would be underestimated. But if the patient has undergone a C3R procedure, that would make the cornea more rigid, thereby causing an overestimation of IOP. So, in significantly irregular corneas, it is better to use tonopen or pneumotonometer or other devices if rather than Goldman applanation tonometer. And tonopen would be a good compromise because that is not influenced by the shape of the cornea in high astigmatism. And also you can, as the planating surface is a very small one, you can take the measurement in an area of the cornea that is clearer. But the problem is that the peripheral cornea is thicker than the central cornea, and that itself would lead to slightly higher estimated IUP. And Pascal dynamic contour tonometer would be better because it is least impacted by corneal thickness, corneal curvature, or irregular astigmatism. In corneal edema also there would be thickening, but here the cornea would be more soft and squishy, and the epithelium of the edematous cornea is easier to indent than a normal epithelium. Hence the IOP that is measured in corneal edema would be lower. Now, position of Myers is very important. You have to adjust the inner edges of the two Myers. So, any of the differences in alignment of the two Myers should be dealt with accordingly. The thickness of the Myers should be approximately 0.25 to 0.3 millimeter. That is about 1/10 of the diameter of the flattened area. The broader the Myers, overestimation is the result, and if they are narrower, underestimation can happen. So if the rings are too narrow, ask the patient to blink twice, thrice, or you can add additional fluorescein. And take care that the IOP is measured within 1 minute of applying the fluorescein. And if the fluorescein rings are too wide, the patient's eyelids should be blotted carefully with a tissue, and the front surface of the prism should be dried with a lint-free material. Blepharospasm can also cause overestimation of IOP, even up to 80 millimeters of mercury. So the biprism, you should take care not to touch the lids or lashes because this stimulates blinking and squeezing. And if the tonometer tip touches the lids, the fluorescein rings will thicken, which may cause an overestimation. Now, some eyes, the fissure will be very small, dermatochalasis, long eyelashes, and blepharospasm, or even reflex or fear of the object close to the eye can all make the patient very difficult to open his eyes. So you'll have to manually open the eyelids, but if you exert excessive pressure on the eyelids, that can overestimate the IOP. And most of the patients, when they sit in front of a slit lamp, they hold their breath out of anxiety or poor positioning, and that will increase the central venous pressure because of Valsalva maneuver, and that will cause an overestimation. Similarly, if they're wearing tight neckwear, that can cause an overestimation. So ask the patient to breathe normally, make them calm, and loosen tight collars for the before positioning them on the slit lamp. Arterial pressure, coefficient pressure, if they go low, can reduce the IOP. And eye position, if the gaze goes more than 15 degrees from the normal, that can cause an increase in IOP, more in restrictive myopathies. Repeated measurements can reduce the IOP, so better do a gonio after measuring the IOP. Diurnal variation is very important. In people who are having glaucoma, it may go more than 8 millimeters, so a single measurement may not suffice. Other causes of variability are also there, including fluid intake, and regularly calibrate your instrument. And another thing is digital tonometry, but that is very inaccurate and notoriously inaccurate. So, tonopen and NCT are other options for measuring, but they may underestimate or overestimate the IOP at other than normal pressures, excess, increased or lower IOPs. So, these are the tips to avoid pitfalls, and you take care of all these and you get a proper measurement of IOP. Thank you.
Thank you, Dr. Ashwati. That was a good presentation. I always feel that if you have too many instruments, too many types of instruments to perform a given procedure, then that means that none of the instruments are good enough. So you have to know about each instrument in detail, and then only you can get a near about reliable result. And second is you have to know about how to calibrate each instrument. Tonopen is so easy to use, but you have to calibrate it again and again to use it. With Goldman applanation tonometry, all of you would have felt to examine a short, stout person with a small neck, it is bound to give you a higher value. So things which, these are the problems, as Dr. Ashwati has pointed out, we have to come up with a better tonometer. Thank you. Next, I call upon Dr. Jayashree. Dr. Jayashree PV will talk on mistakes in gonioscopy.
So, good afternoon. At the outset, I would like to thank Dr. Mallika and Dr. Smita and KSOS for the opportunity. So, I'll be dealing on the mistakes in gonioscopy. As we all know, gonioscopy is a technique used for viewing the anterior chamber angle, and it was initially trained as in 1907 who viewed the angle of the anterior chamber. It was not with a gonioscope. It was in a keratoglobus eye. Why are we not able to see the angle without the help of a gonioscope? That is because of total internal reflection. The light coming from the angle reflects from the tear air interface and goes back into the eye. And that is why we need a contact lens for viewing the angle. It can be a direct contact lens or a indirect prism or mirror. So, whom all we should do a gonioscopy. So, ideally, all the patients who come to your OPD should undergo a gonioscopic examination, but that is not practically possible. So, at least whom all should we do gonioscopic examination? It's like 1 Hz positive patients. In all the patients whom we suspect glaucoma, who are already developing glaucoma patients who all are under risk for secondary glaucoma, those patients in whom we are planning for angle procedures, or those who patients underwent glaucoma procedures, those patients need gonioscopic examination. So mistake number 1 would be not doing gonioscopy. Say, gonioscopy need to be, being a contact procedure, we need to avoid in certain conditions, and also immediately post blunt trauma, because of a risk for the hyphema. Immediately post trauma, we can avoid gonioscopy for some time, but it is very important that after a few days we have to do gonioscopic examination, because we have to rule out angle recession and cyclodialysis cleft, etc. So that is very important for a future glaucoma, like angle recession glaucoma and hypotony in cyclodialysis cleft. What are the commonly used lenses? It will be, in a clinic, it will be indirect lens, like a 4-mirror lens or a Goldman 3 or 1 mirror lens. Which of them is ideal to be used? Ideally, it is a 4-mirror lens that needs to be used. The main advantage of using a 4-mirror lens is that it enables us to do what is called indentation gonioscopy. What is indentation gonioscopy? You apply pressure on the cornea so that you can differentiate what is between appositional closure and synovial closure. Appositional closure is when you press on the cornea, the angle opens up. Synovial closure, this closed angle does not open up. There is a permanent PAS. Why are we able to do this indentation gonioscopy? The inner diameter of the gonioscope is smaller than the corneal diameter. So it presses the aqueous onto the angle and angle opens up. So that is not possible with the other type of contact gonioscope. The disadvantages, it is little difficult initially, and inadvertently you might apply pressure. So inaccurate selection of gonio lens is a second mistake. So where do you use the direct lens? It is for surgical gonioscopy. The major disadvantage is patient has to be in supine position. Well, how do you do the procedure? You have to put a topical anesthetic drop, position the patient at the slit lamp. Patient has to look at the primary position. Elbow needs to be supported. Otherwise, you might inadvertently press onto the cornea. And the room light has to be dim. Otherwise, it can open up the angles. Hand position. You hold the gonioscope with 3 fingers. The 2 of the fingers rests on the patient's cheek. So further pressure is not applied to the patient's eye. The other hand is free to use the slit lamp. The coupling agent is not required here, and lens is applied with very much, with just a touch and interpalpable area only, without touching the lashes as long as possible. And initially you have to use the lowest illumination, the lowest height of the beam that is possible. And when we transit and look at the 4 angles, you can simultaneously look at the 4 angles. You don't have to rotate the gonio lens. So when you are transiting, don't go through the pupil, go through the sides, so that you don't accidentally open up the angles. And after that, you can use a brighter illumination to see the details in the angle. So mistake number 3 here is you are inadvertently opening the angles because of a higher illumination. So these are the angle structures. Schwalbe's line, trabecular meshwork, the anterior non-pigmented, posterior pigmented, scleral spur, and the ciliary body band. Corneal wedge is the thinnest beam and the brightest illumination, the anterior posterior corneal surfaces meet at the Schwalbe's line. And why is this important? Because in a open or closed angle, it is more important because very lightly pigmented open angles might appear as a closed angle because you're not able to identify a trabecular meshwork and you think it is an closed angle. Very pigmented angles, even the Schwalbe's line is so pigmented that you might mistake it for a trabecular meshwork. And so identifying the anatomical landmarks is, just a minute. Yeah, missing the anatomical landmarks is the fourth mistake that you can do. Another one, indentation gonioscopy. You can see this is the Schwalbe's line. When I do the indentation, another line comes behind that. Can you see that? That is the trabecular meshwork. Initially, Schwalbe's line is seen and indentation leads to trabecular meshwork. You can see that I am doing indentation because that DM folds are seen on the gonioscopy. So this is the Schwalbe's line that which is pigmented, and that is the not doing indentation gonioscopy is the next mistake. Again here. Orientation. It is reversed but not laterally rotated. So what is at 1 o'clock will be at 5 o'clock, 12 o'clock, 6 o'clock. So the PI here is going to be here and not here. That has to be remembered. So confusing with the orientation is the next mistake. There are n number of classification systems. Usually used one is Schaeffer system. The grade 4 is open in Schaeffer's. Shea's system, it is closed. And Spaeth describes the angles. So if you mention it is grade 4, it doesn't mean anything. You have to mention the system and then only mention the grade. So not mentioning the system of classification, then it doesn't help. The other mistakes are not repeating the gonioscopy periodically. So once you do the gonioscopy, it's not like one-time procedure. You have to periodically repeat it, not documenting properly, and not following the order of examination. Order of examination, by that what I mean is, if you do gonioscopy first, it can reduce the IOP by 1 to 2 millimeter. So initially do the GAT and then do the gonioscopy. That is the order of examination. And you have to do both the eyes. So gonioscopy is still the gold standard. Inter-observer variability is the most difficulty in that. Practice makes you perfect. Thank you.
Thank you, Dr. Jayashree. That was a very good presentation, really excellent. And I very much liked your comment, not doing gonioscopy is a first mistake. That's a very good comment. Excellent presentation. Now I call upon Dr. Mallika Harikrishnan to talk on the mistakes we make on optic disc examination.
Very good morning to you all. Thank you KSOS for this opportunity. I would like to talk on optic disc, the mistakes we make. Optic disc evaluation provides valuable structural information about the optic nerve damage and its progression, and glaucomatous changes, as you know, in optic nerve head and RNFL may precede defects detected by standard automated perimetry. So we'll go by one, the mistakes. Mistake number 1, faulty examination techniques. What is the ideal method? Is it the indirect ophthalmoscope? No, because it gives a minified view. Is it the direct ophthalmoscope? Until you are in a screening, as a part of your screening, it's okay. Otherwise, it's not, because it's a monocular vision. And undilated fundus examination? No. So what is ideal? Slit lamp biomicroscopy with 60, 78D or 90D. And mistake number 2, you rely only on CDR for diagnosis. You know that 1.2 million axons pass through each disc. But the disc size varies. Think of the leftover space. The space varies with the size of the disc. In the small size, the disc size, the cup will be smaller. Medium disc, the cup will be medium. And the large disc, it is large. So it varies with the size of the disc. What is important is the documented increase in the CDR, cup disc ratio, over time. That is a sign of glaucoma. Mistake number 3. You take rigid decision with IC rule. I know that ISNT rule is very important as a diagnostic part of glaucoma, but what is important, what you have to understand, it is variable, and it also more with the large disc, less with the smaller disc, and there is more reserve in the large disc. The ISNT specificity in Caucasian eyes, it is 85 to 90 percentage, where in Indian eyes it is only 65 to 70 percentage. Just I would like to share an experience. This is the disc of a 12-year-old boy came to the OP with a history of headache. The disc shows very alarming. And we subjected the patient for all the sophisticated investigations, but nothing was found. Finally, we examined the fundus of his father. See, just it is almost similar. So you have to make, as a part of your examination, examine the family member. Maybe they will have a familial type, but you have to take all these things into consideration. That is my message. So mistake number 4, too much importance to parapapillary atrophy. As you know, beta zone is more important as far as glaucoma is concerned, which indicates the atrophy of the RP and the choriocapillaries. But it is, what you have to understand, it is not specific or sensitive enough to be important. What is important is always look for whether a new beta zone is appearing or is there any enlargement of the beta zone. Number 6, not looking with the red free photograph. That is a very bad mistake, because for the beginners to detect the RNFL defect is with the fundus photo or fundus examination will be a little difficult. So as you see in the picture, it will be difficult here, but for the expert it is easy. But if you look at carefully, you can see a superior notch, but when you examine under the red free light, you can see the RNFL defect, wedge shaped RNFL defect. So suppose it is a patient with so much of tessellated fundus, it is even more difficult. But if you look at carefully, you can see the superior notch here, and you can correlate it with the field. You can see the corresponding field defect inferiorly. Mistake number 6, differentiating with the myopic disc and tilted disc. That is the most important thing. It is very difficult because the myopes have a large disc, shallow cup, tilted often, and the fibers are stretched. Temporal displacement or convergence of the vessels will be there. False inferior and nasal thinning will be there. You should always have a high index of suspicion. So one important point I can point is that go largely by the contour cupping rather than a color cupping. And this thinning, notching, everything is masked because of the parapapillary atrophy also. Another important point you can follow is that use a 2 mirror with a coupling fluid and use the central lens that can differentiate the notch better. And another important thing is you can apply Joe's rule. I will come to that. And always important is that look for the family history or look for the progression. Joe's rule says that unless and until proved, you have to consider all this have glaucomatous changes. All glaucomas have RNFL defects. All glaucomas have disc hemorrhages, and all myopes have glaucoma, unless otherwise proved. And tilted disc may be glaucomatous, that may be familial, and it can be of high risk also. It may be congenital or associated with myopic tilted disc, may have no field defect, but they can have field defect as well, as you see in this picture, but that field defects remain stable. And what you can do is you can treat the patient if the IOP is high, and you can also consider the family history and always look for the progression as per the field effects. Mistake number 7, differentiating with a neurological disc. What is this disc? It's very obvious. Neurological disc. Pallor out of proportion to cupping. That's a sign of neurological disc. So you can see the field also, you can correlate that it corresponds to, it respect the vertical meridian. But what about this cup? There is a diffuse pallor, but here cup is more. It's more of a glaucomatous cup. What is this disc? Here you can look for the location of the kinky vessel. Here the cup is more. Cup is more than the pallor. This is also a glaucomatous cup. But what is here? What is seen is the disc is very small, but it is paler. Cups are shallower. CD ratio is smaller. This can be more likely an acute congestive glaucoma. So, in short, if the cup if the cup is equal to pallor, that is normal. If the pallor is more cup, it is a neurological disorder or a glaucoma with very high IOP. If the cup is more than pallor, it may be glaucoma or maybe it may be normal. Number 8, disc with myelinated nerve fibers. So here, follow the disc where the myelinated nerve fibers start from and assess the NRR at that level and compare with the other part of the disc. But suppose the disc is all around, it is covered by the myelinated nerve fiber. There is no alternative. Glaucoma management is based on the IOP and the pachymetry. And the field also, it may or may not be reliable. OCT is not at all reliable. So to conclude, optic disc evaluation remains one of the vital diagnostic tools in the management of glaucoma. Mistakes can be minimized by the systemic evaluation techniques and serial documentation and correlating well with the OCT and the HFA findings. And after hearing my talk, if you see a disc like this and you feel the this call alarming sign, save me please. I am very thankful to you. Thank you so much.
Thank you, Dr. Maliga, for that excellent presentation. Next, I invite Dr. Smita for her talk on the mistakes in OCT evaluation.
Good afternoon, ladies and gentlemen. So today I shall point out a few mistakes that we are likely to make during our interpretation of the OCT RNFL. So today I shall be basically talking about the retinal nerve fiber layer and the ganglion cell layer. and the ganglion cell layer, and OCT. Sorry. And OCT is the only instrument which can directly measure the thickness of these layers. So most of the other instruments were unable to measure it directly. OCT is the only one which can measure the thickness directly. So what are the pitfalls that we can encounter? So first is about the signal strength. So today most of my my printouts are of the Heidelberg because my hospital has a Heidelberg, and I have also incorporated a few Cirrus printouts. So it is important that we have the right signal strengths. So these are the signal strengths for each of the machines. For Spectralis, we need more than 15. For Cirrus, we need more than 6. And for Topcon, we need more than 60. So this is the place where the signal strength is given. So you can see that the signal strength is 31 in the printout in the right eye and for 30 for the left eye. And in the Cirrus printout, it is only 6 in the right eye, which is just adequate. And for the left eye, it is 5, which is actually inadequate. So the conditions like say having a dirty lens or a dry eye or the presence of cataract, and even paradoxically a posterior chamber IOL can decrease the signal strength and therefore decrease the quality of your OCT RNFL. So these have to be looked for, and these can cause mistakes in your OCT RNFL assessment. So what does a poor signal strength lead to? A poor signal strength is best seen by a poor. Can you tell me how to use this? Okay, if you look at this area does not show the details of the blood vessels, the finer blood vessels. It is dark. So when you look at this position, that this is a temporal part, the temporal part appears dark red over here. So even though we do not need the temporal portion in the management of glaucoma, you can see that poor signal strength, which has led to a grainy B scan, has led to the poor delineation of the blood vessels in this area, has led paradoxically to a thinner OCT RNFL in this area. So this thinner OCT RNFL, you have to remember, is because of poor signal strength. So do not take OCTs which have poor signal strength, discard them. Another important factor to be looked for is decentration of the measurement ring. This measurement ring center should coincide with the center of the optic disc. This is a decentered ring which has been exaggeratingly decentered. So you will find that in the Tisnet profile, everything appears very abnormal, and also some of it is supra thick. But when it is centered properly, you can see that now the contour and the thickness appear normal. So second mistake you can have is a decentration. More than 10% decentration in any direction will lead to abnormalities in the measurement of the RNFL. So over here you can see that this portion, you know about the ISNT rule. In most of the patients, the inferior rim is the thickest, next is the superior, then the nasal and the temporal. If this measurement ring moves superiorly, then it means that you are going to measure a thicker area inferiorly as compared to a thinner area superiorly. So there is a higher chance of violation of the ISNT rule. So, sorry. So, decentration is a very important thing to be looked for. So, first is you look at the signal strength, and second is you look at the centration of the ring. Immediately after appropriately positioning the ring properly, you look at the structures under the ring. So over here you can see a black area. So this black area will prevent the acquisition of the scan in that position. So this is corresponding to this position, and you will find that the scan is not taken appropriately, or there is a thinning in that area. So when you look at the measurement ring and you look at the position of the black area, which is actually a floater. So when this floater has moved away from the circle of measurement, then the scan is okay. But this floater under the circle of measurement prevents the acquisition of an accurate scan. So that is the third mistake that you have to avoid. That's the third pitfall that you have to avoid. In this Cirrus printout, you can see a floater which is abutting on the deviation map. In this deviation map, you can see it is abutting on the measurement ring, and that is why you see in the infratemporal portion there is a thinning in the thinning in the Tisnet profile or in the measurement circles. Motion artifacts, they are basically now rare because the instruments have incorporated correcting features to it. But in Cirrus, you can identify it by looking at the blood vessels. So if you find that the blood vessels are cut and there is a horizontal line like this, then it indicates that there is a motion artifact, and so such a printout should be discarded. Cut edge artifacts happen more in places where student technicians are working. So they are likely to take a printout where the details in the edges of the OCT are not available. So the cut edge artifacts are, so such printouts are usually the first ones that are taken, and therefore they also have to be discarded. So this is a cut edge artifact which shows a red color in the edge. So this is basically not only seen in when a printout is being taken by, when an OCT scan is being taken by a technician, it is also seen when you have patients who cannot sit properly. So like say in a high myope, very high myope, it is difficult to take an OCT scan, and that can give you a cut edge artifact. Misidentification of the RNFL can happen, and so you have to look at the screen. So that screen may show so see here there was some failure of algorithm, which led to a misidentification. So when the scan was repeated, then the contour and the thickness became almost corrected. So that it is very important if we can see the screen and look at the red line which indicates the inner limiting membrane and also the outer portion of the RNFL. You have to look at their position and therefore identify the failure of the algorithm. Sometimes PVD can cause a traction, and this traction can cause a thickness of the RNFL measurement which actually is not there. So a serial follow-up will actually, when this traction is released, this can collapse and you might think that the RNFL has thinned down. So serial follow-up should allow you to look at these structures to know which portions are being measured, and so therefore it is very important that we look at the B scan of the patient to identify these conditions. Posterior misidentification of RNFL is a less common condition. Over here, a large blood vessel has caused a failure of the algorithm. You see this area is also dark, and this blood vessel, which is identified over here, has caused a failure of algorithm. So the machine is measuring a sort of a guesswork. A machine is doing a sort of guesswork, and you find that this area is very much thickened. So it is like a supranormal thickness. So again, identification of this area on the screen of the machine is very important. Floor effect, I think by now almost everybody knows what is the floor effect and what is the parameter to be taken for each machine to be considered as floor effect. So for spectralis it is 49.2 and for Cirrus it is 57 microns. For RTView it is 64.7. It means that there has to be some amount of tissue, including the blood vessels and the glial cells, which are not destroyed, even though the glaucoma has come to an advanced state. So if you have the Tisnet profile showing that this line or this actual measurement of the patient is touching the floor, then this has to be reworked, remeasured. This I've already discussed. Green disease means that the person is classified in the RNFL as not having the disease, even though you see that there is an RNFL defect over here. By the way, RNFL defects are best identified from fundus pictures as compared to our own examination, and you can see that even though there is an RNFL defect, this appears green. So in this case, we are missing a diagnosis of glaucoma, or we are missing a proper examination where this patient needs a more thorough examination. There are many instances where normative database is not available. PGI Chandigarh is actually working on smaller children and giving us a normative database for Indian eyes. In instances where normative database is not available, we have to go for the macular parameters. This is the normal RNFL thickness for the Indian eyes, which is about 8 to 12 microns thinner than the Caucasian eyes. And since our reference is the European database, we have to keep that also in mind and prevent a mistake of labeling a patient as glaucomatous. So the red disease where we label a patient as glaucomatous leads not only to an unnecessary diagnosis, it also leads to unnecessary treatment and the side effects of those treatment, and also to unnecessary litigation. Now, this is a very, very rare instance. I personally have not seen such a case. This is from the literature where you have a split RNFL. You can see the split over here, which is a normal anatomical manifestation, which leads to thinking that this might be a notch or leading to a glaucoma. And this also causes a lateral shift of the RNFL bundles. Again, this patient is more likely to be labeled as normal. The risk factors for creating the artifacts which may cause us to mistake it as glaucoma are poor visual acuity, cataract, and advanced glaucoma. So my take home message is, in order to prevent the diagnosis, never base your diagnosis solely on the OCT. Spend time on examination of the optic disc and correlate the findings with the disc and look for the signal strength and decentration. Thank you very much.
Very correctly said take home message. Thank you, Dr. Smita, for that very simple and very meticulously presented. Next, we have pitfalls in perimetry by Dr. Danya Chiret.
A very good afternoon to all of you. At the outset, let me thank KSOS and Malika ma'am for this opportunity. My topic for today is pitfalls in perimetry and how we can avoid a few mistakes while doing them. So we can consider this under 3 headings. What should you think while advising a visual field test, while performing the test, and while interpreting the test? When we advise a visual field test, we have to consider the patient demographics, like are there any comorbid conditions? Does the patient have any illness which will inhibit him from doing the test? Like, for example, a Parkinsonian patient with tremor, or a patient with hearing loss, or a patient with a cognitive dysfunction. So for such patients, we can do, instead of the full threshold strategy, we can do a CETA program. Another thing is about the language barriers. Make sure that the patient will understand the language that you're speaking. Coming on to performing and interpreting. While performing, it is better that the testing technician or the optometrist has done a self-test on himself or herself to know the nuances of the test, so that they can understand it better to the patient. Patient needs to be comfortably positioned. Always ask them to encourage the patient and reassure that the test can be paused in between, and you can communicate to the patient that we can always do this test next time. So then there's nothing to worry. The world will not stop. So you can always do the test at a later date. And also, it is important to inform the patient that you need not press the button at every sea of light here and there. That is, the fixation has to be kept in mind, and mindful that the lights will shine at varying intensity at 4 quadrants. You look at the center, and whenever you see the light, you press the light. This is what I said about positioning. A comfortable positioning will go a long way in performing the test. So it is easier for the optometrist as well as for the patient. Data entry. If not the date of birth, at least the year of birth has to be accurate, as we all know, because the essence of the test is to compare with the normative database. Make sure the best corrected visual acuity is entered properly, the pupil size, and you choose the correct strategy for the type of patient. Also, repeat the same strategy when you do the test next time. Use rimless lenses and not those lenses from your trial frame, because that will create an edge artifact. If you have an added astigmatism, use a spherical equivalent and don't put 2 lenses in the same frame, because that will again cause an error. High myopes or high hypermetropes, you can use contact lenses, again to avoid the defects which can be caused. Make sure that the fellow eye is closed properly, otherwise that eye will keep on wandering and it will cause a lot of fixation losses. Make sure that the fixation is not turned off during the test. Gaze tracking is very important. Some patients will not be able to fixate properly. So it is our duty, the technician's duty, to see on the frame, and that is on the monitor, that the pupil repeatedly, they have to make sure that the pupil is in the correct position, that is in the center of the green, so that we have to make sure that the patient is seeing properly. We also have the gaze tracking. The gaze tracking, if there are multiple deflections in the upward direction, it shows that the patient is not fixating properly. And if there are deflections downward, it shows that patient is frequently blinking. So make use of both the techniques, like the monitor as well as the gaze tracking, to know that the pupil is in the right track. Coming on to interpretation, a systematic interpretation is necessary. When you get a printout, just you have to see whether this is a printout of my patient, that specific patient. That is the first thing. And then the reliability indices, the fixation losses, false positives, and the false negatives. The next thing is, can we rely on the grayscale? How much importance do we give to the glaucoma hemifield test? And how should we assess the visual field index? Now let me read out this printout. So you can see this is the printout of a 45-year-old, and the reliability indices look good. The program done is a central 24-2. The strategy chosen is CETA standard, and always look at the visual acuity and the foveal threshold hand in hand. Raw values in grayscale, you can have a quick look, and then look at the total deviation and the pattern deviation plot, number 6. Total deviation plot and pattern deviation plot has both a numeric value, which you see in the upper part, and down you can see the probability plot. Then we come to the global indices, number 7, that you have the 4 major global indices: the glaucoma hemifield test, the visual field index, mean deviation, and the pattern standard deviation. So this is our printout. Now, let's go into the detailed check of this printout. So this is a visual field showing a fixation loss. The machine itself tells us. You can see the arrow there where the machine itself has flagged as fixation loss. You can see 2 cross signs there, and the triangle there shows low test reliability. So the machine has made it easier for you. So the blind spot, so what could have happened is that the blind spot was not mapped correctly, the patient was not fixating on the central target, or it could have even been a trigger happy patient, or the other eye was not occluded properly, so patient kept on moving the eyes, or a head tilt. Now, false positives are always happen with the trigger happy patients, and in the grayscale you can see white scotomas. Machine says the learning is that 33% is okay, but it is always better to be cautious, and if the value is more than 20%, it needs to be reevaluated. So false negatives can happen either due to a fatigued eye, inconsistent responses, or in advanced glaucoma. Can I rely on the grayscale? Grayscale interpolates and create a picture of continuity, and it is easier to explain to the patient. But it is not statistically significant, but you can have a quick look at that and see whether there are any patterns, for example, the clover leaf pattern, or if there is ptosis, or if there is a white scotoma. So for that you can use. And how much importance do I give to GHT? Glaucoma hemifield test is based on 5 zones, 5 points in the upper zone and the mirror images in the lower part of the field. So that is how it is compared. And remember that the points are same in the 24-2 as well as the 30-2 test. So that doesn't make a difference. The 5 possible messages, GHT messages, are outside normal limits, borderline, generalized reduction in sensitivity as in cataract, abnormally or any other refractive errors, abnormally high sensitivity, or within normal limits. Outside normal limits mean that the upper points, the 5 upper points and the 5 lower points in both the hemispheres, they are significantly different. So this becomes important because they have been based on specific glaucoma points. So this is very important, outside normal limits. So anything which doesn't fall into the ONL comes as borderline. Now VFI ranges from 0 to 100 and is expressed as a percentage of visual field. Remember that VFI is always calculated from the pattern deviation plot. But if your mean deviation is more than 20%, that is calculated from the total deviation plot. So a few examples. So this is a young myope disc suspect. You can see a visual field with on the left with a central fixation defects, and on the right there are no fixation defects. But for this 19-year-old, it is mandatory that you do a 10-2 to pick up the early defects in the right eye. This is a post-trab one-eyed patient with a superior arcuate as well as an evolving inferior arcuate. Again, you have to do a 10-2. In advanced glaucoma, it is mandatory you do a macular threshold as well. A PACG patient, the other eye of the PACG, the better eye of the patient, you can see the yellow circle, you see a rim defect. But remember that the rim defect, it is a 24-2. So this cannot be considered as a rim defect. You have to repeat the test and make sure that if this point persists, that rim defect like thing persists in a 24-2, you have to consider it as glaucoma, and you have to do, clinically correlate and then start treatment if required. Now, always understand the importance of repeating the visual field test and importance of creating a baseline. This is a test of the same patient who has been repeated like after 15 minutes, and you can see the difference. From low test reliability, it has gone to normal. So remember that in your glaucoma clinic, all patient does not have glaucoma. Some might have neurological field defects. Okay, so this is a homonymous hemianopia. And to avoid mistakes, a well-instructed patient, a skillful and a patient optometrist, patience is very important, and a clinician systematic approach can help in the diagnosis and assessing the progression, thus helping with the scientific management plan. Thank you so much. The mistakes will continue and we have to keep on correcting them. Thank you so much for your patient listening.
Thank you, Danya, for that lucid presentation. Now we go on to the last talk on this session, that is common mistakes in treatment by Dr. Bindu S. Ajit.